First and foremost is you have to inform and engage the patient as well as the attendant. The patient should be thoroughly informed what is ERAS. It reduces the anxiety and makes the patient to involve with the protocol so that the compliance is better. Next is carbohydrate loading. It reduces the insulin resistance, improve patient well-being, minimize preoperative fasting and possibly provides a faster recovery. The third important thing is preoperative prophylaxis against thrombosis. Here, it reduces the thromboembolic complication. The patient might be on hormonal replacement therapy or patient might be taking oral contraceptives. These are the things which you should avoid to reduce the thromboembolic complication. And another most important thing is the NPO status. Here, you stop solid for 6 hours and continue clear fluids 2 hours prior to surgery. This again reduces the insulin resistance, improve well-being, minimize preoperative fasting and possibly provide a faster recovery. And this is mainly for gastrointestinal or colorectal surgery, bowel preparation with oral antibiotics. Usually bowel preparations are avoided in other surgery, but in colorectal surgery, bowel preparation has to be done. It decreases the rate of surgical site infections in patient undergoing colorectal surgery. Coming to general preoperative prophylaxis against infection, it reduces the infection rate, which is very, very important. Sepsis can prolong the hospital stay. Coming to prophylaxis against nausea and vomiting, you have to take enough precautions to avoid PONV so that it minimizes the postoperative nausea and vomiting and the outcome is better. Coming to the intraoperative event where anesthesiologists play a major role. First is use of minimally invasive technique. By using minimally invasive technique, you reduce the tissue trauma, you reduce the pain, you reduce the inflammation and everything leads to a better outcome. You can easily fast track the patient. Here, you have reduced complication, faster recovery and reduced pain. It might be minimally invasive for surgeon, but maximally tiring for the anesthesiologist. Again, intraoperative prophylaxis against thrombosis and blood loss. You have to take precaution against thrombosis, but at the same time, you should use precautions to avoid blood loss. For example, if it is going to be a vascular surgery and you expect major bleeding, you can go ahead with some antifibrinolytics to reduce the bleeding, or it is a redo surgery or something like that. You can go for an antifibrinolytic infusion if you anticipate bleeding. Your target is to reduce the thromboembolic phenomenon, but not to forget the bleeding also. And coming to anesthesia, avoid long-acting opioids. Opioids used to have a delayed recovery. Go for a multimodal analgesia with standardized pain management process and avoidance of long-acting opioids. By doing that, you avoid postoperative ileus and respiratory depression. Another important thing in the intraoperative period for ERAS is the fluid balance. Okay, you should not overhydrate as well as lead to dehydration. Nowadays, the concept is you have to maintain the blood pressure not with fluid, but use of vasopressor to maintain the blood pressure. More than fluid, you use vasopressor to maintain the pressure. It reduces the complication and reduces the postoperative ileus.